This episode is brought to you by podiatrygrowth.com/podpatrol.
So for the Pod Patrol listeners, what should they do to take advantage of the assistance that you can provide?
I worked with Jeff here to create a 5-day email course talking about 5 different systems that are going to help you drill down on what's important as far as gaining new patients. And if people enjoy that, I always have the option of 30-minute free strategy session where we kind of go over what people's current challenges are.
So a 5 email introductory course. That sounds expensive. What are we paying for that? $1,000, $10,000? What are people going to expect to pay for that introductory course for them?
Yeah, this is a free gift to my colleagues. Just gives you an opportunity to do a bit of a self-assessment.
If anyone's interested in more information, they can go to podiatrygrowth.com/podpatrol.
Podiatrygrowth.com. Every step matters. Pod Patrol. Pod Patrol. Pod Patrol. Every step matters. Feet hit the ground, we rise, we climb. Ain't stopping now, it's our time to shine. Turn it up loud. Pod Patrol. Pod Patrol. Pod Patrol. Pod Patrol. Every step matters.
All right, welcome back to Paw Patrol with your host, Dr. Jeff Dikis. Tonight I'm joined by Dr. David Sipala. Thanks for joining me tonight.
No, Jeff, thank you so much for having me. Definitely been watching your podcast for a little bit now, and definitely an honor to be on.
Yeah, absolutely. So for anyone who doesn't know, you're out there in Boston and you're a residency director, but take us back a little bit. Tell people where you went to school, where you went to residency, and then what you're up to now out in Boston.
Yeah, absolutely. So originally from New Jersey, went to medical school in New York, went to NYCPM and that's where my kind of journey started. Did a couple of residency externships out in Jersey, but also wanted to venture back to the New England area. Went to undergrad at Boston College. So Boston's definitely kind of like been a second home to me for a long time. So looked at residencies in both locations to family, but also to where I wanted to end up, and landed at a hospital known as St. Elizabeth's Medical Center, a PMSR program, did a lot of reconstructive surgical training under the guidance of JT Marcoux, Jay Phillips, both big PI guys. So really got my hot spot and first spot that I wanted to go to, which was ironically the hospital right down the street from my undergrad college. So was also familiar with the institution.
Sure.
And went there and graduated in 2015. And from there, kind of bounced around to private practices. I was in a private practice with one of the attendings I worked with through residency, kind of very standard podiatry practice, with a lot of routine medical care, diabetic care, with a touch of surgical, cases that I was able to kind of get busy with, but starting slow and just getting my feet wet. And then as I started to see that I was outgrowing that, after about 2.5 years, I ventured to another podiatry practice, but going north of Boston. And they were looking for basically a surgical podiatrist. And that kind of seemed like, this is my calling. This is what's going to fit me. And I was still kind of in that zone of wanting to stay private practice forever. I just kind of liked the feel of it. But did that for a couple of years. And in the same vein of that, in the same institution and that hospital and that practice was affiliated with, there was an orthopedic group that was looking for a DPM. And that just was kind of another calling where I could further branch out surgically now to trauma, especially too. So then went there for a couple of years. So every 2.5 years, there was just opportunities for me to grow, and I kind of was bouncing around. And not that I loved to change practices every couple of years, but it just was the opportunities. And then after a couple of years there, my old residency program, there was a spot open for the residency director, the director that took over after the guy that trained me. And now I'm the director of my alma mater of residency. He kind of just didn't really take it under the reins of taking on the role of training residents and really allowing them to be exposed to stuff. So it just was kind of faltering, and it got to a little bit of a kind of a lull, and the residents were feeling that, and the program and the hospitals feeling it, and just opportunity arose, and they approached me, and I was ready to go with that next challenge, practice life, building up my surgical practice and patient and my clientele was great. But now this was kind of like the next calling for me of being able to train residents in a much more centralized way.
Yeah, you have quite the experience there. So I think this will be fantastic for people to hear because you have experience in private practice and
Yeah.
orthopedics. And now, are you
Yep.
employed by the hospital itself?
So yeah, so now as I was saying, like being private practice, thinking that's what I was going to be doing for the rest of my career. Now hospital employed. Yeah, so I'm. It used to be St. Elizabeth's, as I said, where I went to my residency. That now got bought out and became what's called Boston Medical Center Brighton. There's Boston Medical Center downtown Boston, a state hospital that's been around for a long time, and actually St. Elizabeth's was owned by a different system known as Steward that unfortunately went bankrupt, and that was another reason for the turnover in the program. So
Hmm.
a lot of instability. And I think me taking the opportunity was potentially a little bit of a risk, but again, one that I thought was valuable and worth that risk. And so Boston Medical Center bought them out. Now they're called BMC Brighton, but same institution, same place where I had my roots and established my roots. So it was like going home. And being employed by the hospital definitely has differences. I definitely see that, but there's definitely a lot of pros and cons.
Let's talk about that here in a second. Before we get there, I want you to tell some of the younger people, just give a little rundown on your program, how many residents you take, do you take externs, all that stuff for anyone who's younger who might be interested in checking it
Absolutely.
out.
Absolutely. Yeah, that'd be great. I mean, we are a PMSR program, as we said. That's a 36-month program that's in credentialed for rear fit, reconstruction, and ankle surgery. Everything from reconstructive to traumatic surgery. In terms of the volume that we do and we cover, we take 2 residents per year, so 6 resident team total. We do take externships, 2 per month, actually. And, we allow them to shadow in our clinical setting, in the operating room setting, and sometimes try to get them out to some of the other affiliated hospitals, ancillary providers that they also scrub with to just get them full exposure to our climate, to our teaching style, and, really give them the full experience, because obviously we're doing a 1-month interview with these students, but they're doing a 1-month interview with us. And I'm very passionate in what kind of student we can mold and really grow. But I also want the student to get the full gamut of training and what they can be set up for success. So I love for the externs to get that full experience. So I think 2 per month has been working for us to give them that full and not be too overwhelmed with too many students and not able to put them. So we've been getting geared up for obviously interview season, but so now having as many externships in the latest months, but we've been getting busier with those students coming through. And it's been great. It's been really good.
Good. And that's Boston Medical Center Brighton
Right.
specifically.
Correct.
And
Correct.
there's a few programs in the Boston area, aren't
Yeah.
there?
There are definitely quite a bit. And that's kind of nice. It makes it a community. So I find it's nice to have our own specific identity, which we've been establishing from the surgical work we do, the academics, and also the research. Some things that were a little bit on the lacking side in the last couple of years. So I'm really trying to build that up and
Hmm.
again, establish ourselves as a definitive and individual program. And I say that because there's Beth Israel Deaconess, which is right down the street from us, ironically run currently by the residency director that trained me. So when he left this hospital, that's where he went, and he's the director there. Having that close relationship with him, as well as proximity, we do a lot of mutual didactics and mutual academics. So that's another little caveat that I like students to see that you may end up at our program, but we're doing a lot with the other programs. Cambridge Health Alliance, again, the director that trained me, that's where he actually started that program. So as you can see, there's a lot of kind of overlap and consistency, but still some differences in each program. And we do quite a bit of work with them. And Boston Medical Center, main campus, which is downtown Boston, they actually have their own program. And sometimes it gets a little unique. And we were trying to clarify that as we got into interviews and applications, is that we were just showing up as BMC and we're like, no. We have our own program and we have
Yeah.
and our own identity. But there is a number of programs and we all have a really good relationship with one another.
Sure. That's nice, especially if someone wanted to go and not travel all the way across the
Right.
country. Let's say they were interested in Boston, they could bounce around to a few
Oh,
different
absolutely.
programs there. You and I were talking before we started recording about how much I like Boston. I went there for the first time a couple years ago and loved it. It was fantastic. I'm not a big East Coast guy.
Yeah.
I'm from the Midwest, and
Yeah.
Boston was fantastic. I don't know what I thought. I thought the people weren't going to be very friendly, but they were. They were super friendly.
Well, there you
I'm
go.
sure if I went to the wrong neighborhood, just like anywhere in the country, you'd find
Yes.
some people that maybe not all of them are friendly, but when I was there, everyone was fantastic. The lobster rolls, the USS Constitution, the aquarium. We did the little trolley
Yeah.
ride where you hop on, hop off, and the guy tells
Yes.
you about everything, and you just have to. It was funny because you could tell that the locals hated these trolleys. You're on the trolley, and they're just like tourists looking out the window, and people are like honking. Like, I'm sure they just hate these
Get it out of the
stupid
way.
trolleys that are there all day, every day.
Absolutely.
But for anyone who's never been to Boston, tell them a little bit about Boston and what it's like.
Yeah, I mean, growing up in New Jersey, going to the New York school, and being immersed in New York City as the city that I grew up with, that was actually where I thought I would end up, to be honest with you, very early on. But then, as I said, I went to Boston College, got my real first experience with Boston and living in Boston with my undergrad, and loved the college experience, but also appreciated the city. And very kind of different. I know sometimes it gets compared a lot, but it really shouldn't, because Boston's a completely different city. We call it the town for a reason, because and also famous for the movie. And there's a reason, because it is a city. There's a lot of hustle and bustle, but it's a smaller city. Okay, there's a lot going on in a smaller area. And geographically, it doesn't span a whole big area of the state, so it's very condensed, very easily managed to get around. That's why there's so many people that bike or go everywhere and don't even necessarily even have a car. So it's, to me, was much more of a manageable city, very clean, and livable. You know, living in New York, people do love that grind and that hustle bustle, and I again did that for the years I went to medical school. But it can get a little tiring, and with the stress that we sometimes are under with our careers and our lives and what we do, I quickly learned, I'm like, yeah, this is probably not where I want to end up. And Boston just had that allure. So it's great for history, tons of history. The food scene is great. Seafood, of course, obviously. So that's a big draw if you're a fan of that. The winters, everyone harps on that too. And I mean, we've been pretty mild for the most part, but it can get a little rough in the winter months. But spring, summer, and fall are all gorgeous. So to me, it was just, that became my home. It was an easy choice.
Yeah, I deal with that in the Midwest, where people are like, isn't it cold? Like, yeah, but people, for some reason, they ignore how hot Texas and Florida and Arizona are. Like, here, it's terrible in December or January. There, it's terrible in July and August. It's just a different,
Yeah.
it's, and I appreciate the 4 seasons that we get with the
that's
weather
what
changing.
I love it too. And we don't get any of the significant, except for snowstorms, we don't get really hit by some things like earthquakes or hurricane season or anything like that. We really don't get a whole lot of other, deterrents for weather-wise. So it's a great city to live in. It's a lot going on, and definitely enough for me to live my life and still have good quality of living, but get the city experience. It's nice.
I want to talk a little bit for anyone who's interested in discussing the differences between private practice, orthopedics, and hospital employed. I'll let you kind of take the floor and maybe talk about some of the pros and cons of each of those models that you've discovered moving through from one to the next.
Yeah, no, absolutely. So I think when it comes to a private practice model, I think there's definitely a bigger sense of autonomy in the practice you're in, whether you're a partner of that practice or not. Even starting out, you have a lot of autonomy with the partners or the employer of your practice. You have a lot that you can do and say to mold what you want to do, in terms of what kind of demographic, what kind of things you want to treat on or want to focus on. We talk about a podiatry all the time. You can really kind of put yourself in a variety of niches based on your interest. That's what's great about our profession, whether it's wound care or reconstructive surgery, trauma, pediatrics, limb salvage stuff. And so with private practice, the pro that you can kind of mold your practice and kind of market yourself in a way, much more freely. That's, I think, one of the bigger differences, I would say. And that's talking in terms of podiatry practice, especially those that currently employ us that are a little bit on the older side of it, and us younger guys coming in. There is a little bit of a difference in terms of our training and what we're capable of doing. And podiatrists that employ us know that, and they're knowledgeable of that. So this is kind of be my segue into orthopedic private practice.
Real quick, would you say one of the negatives of private practice, at least in my mind, would be sometimes you don't have the established referral patterns that you'd like, meaning that trauma, certain things are going to go to certain groups, whether that goes to the hospital employed person, to orthopedics, whatever it may be. And private practice has to fight, or even the model that I'm in, which is multi-specialty, and I have numerous family practice doctors who are just going to
Yeah.
feed them right into my practice that's just built in.
Yeah.
They fight against a little bit of the referral pattern. Depends on where they are. If they're the only show in town, they maybe may not have to deal with that. But what are your thoughts on
Oh,
if
yeah.
you're at private practice and you're really into trauma, maybe that's
Mhm.
not the best
Oh,
situation?
no, I would definitely echo that. So I'm glad you brought that up in terms of just private practice in general and our profession. Is you do, it is a fight to really market yourself, get your name out there. And I had to do that. Yeah. I mean, those referrals, going to practice, I mean, it's even one aspect that I wouldn't be able to touch on is opening your own practice, which is a whole different gamut.
Right.
But going into a practice that's already established, okay, there is a little bit of an in with some of the private practitioners in the hospital you're affiliated with that know who your employer is, who your practice is, but they just don't know you. So it does take some work of you getting out there, getting your name out there, maybe doing some in-service or doing some lectures at the hospital. I did a lot of, getting my name out there in that way, just to kind of show not only who I am, but also these are some examples of cases and things I was trained in.
Did you see a
Trauma.
did you see a
uh,
difference when you did that? Did you
I did.
notice a difference?
Yeah, I think I did start to see definitely a difference. It wasn't right away. It wasn't overnight. It took months and months. And again, working in a podiatry practice that knows that it's going to take some time. They're patient with your progress, and it may not be overnight with the productivity. That's good. You don't have that pressure. But at the same time, if you just sit on it and just rely purely on referrals that of doctors that don't really know you, it's going to become stagnant. You will
Yeah.
plateau, I think, pretty early. So getting your name out there and doing some of these lectures and just being proactive, visiting offices and bringing your cards and whatnot, it definitely made a difference to some degree.
Mhm.
But as I said, it just takes time. And I think being affiliated with a hospital and taking call, that's some other thing that some providers is they don't want to be bothered by call, which is fine. You just want to be in your private practice. But to really grow and myself taking call when I did, I think that helped me get my name in the hospital system too.
Sure.
And that really definitely turned things over. Trauma, as you said, I mean, that didn't really come to me until I got to orthopedic practice. So that was kind of my segue there, where in private practice podiatry, I really tried hard. I got a couple of fractures here and there, but you're absolutely right. It's going to go to the hospital-based doctors, and especially orthopedics, or any orthopedic that's private but affiliated with the hospital. So that's
Right.
a tough niche.
Yeah. Those are tough referral patterns to break.
There.
The ER is used to calling a certain group or a certain person, and
Yeah.
they don't want to have to they don't like breaking those referral patterns. Hey, they know that if they have a broken femur, humerus, clavicle, ankle, whatever,
Yeah.
they don't want to have to be like, who do I call? They just want to call one specific group. And I found those referral patterns are very difficult to break because they've been set in their mind of, okay, it's a bone, call orthopedics. And so if you work for the orthopedic group, in my experience, which is where I used to work before my current job, then if you have a good relationship within the orthopedic group, then that trauma does come to you because you're working for the orthopedic group. You're working with instead of
Yeah.
paddling upstream. So, what was your
Absolutely.
experience like with orthopedics? Did you
Yeah.
enjoy the model and the
Yeah.
ability to do more trauma?
Yeah, I think it really opened up where I was with each practice I was venturing to, I was kind of expanding my surgical work and especially on a reconstructive standpoint. But when it came to trauma, yeah, I was kind of stagnant there. So joining the orthopedic group not only helped further expand my exposure, and to be honest, as a DPM and near an orthopedic practice, there automatically comes a little bit of a boost in terms of other hospital employed hospitalists and primary cares that know what you're about, in terms of what you can provide, and surgically trauma wise as well. And you also have a relationship with orthopedists that brought you on. They see that the work you do and trust that. So some of the times that they don't want to do any of the lower extremity and ankle stuff, and they're just feeding you that, it becomes a nice relationship, a nice back and forth. I will say, they're definitely looking at us, and I think it's important when you join an ortho group that you're ready to take that on and be able to perform at your highest without, that pressuring yourself and, relying on your capabilities, because they are looking at you and want to see those results, that they trust you, but they want, really good optimal results, especially being a DPM. So they still have that one eye on you. But I think it's a great relationship and opportunity for anyone to go after, with the knowledge and the training that you have behind you. Absolutely. Especially if you want to do trauma.
And then how would that compare in your mind to being a hospital employed provider?
Yeah. So as you were saying too, just from a referral standpoint, without even really getting started there, my clinic schedule was already kind of filling up, before I had the first day I even started.
Right.
And that was a range of all podiatric issues, but also trauma. The nice thing about our program that does sometimes vary from other programs, we're not the only ones, of course, but we fall into the Department of Orthopedics, not general
Hmm.
surgery, although the other residency programs are all under the surgical, general surgery, and internal medicine departments. But what's nice is that we're in the Department of Orthopedics. They don't have their own residents. So trauma wise, they'll get all of it. Obviously, we have a trauma team. Some of them, just even today, they get really super involved and busy with other cases, and ankles coming in as we speak right now, actually a try now. And they're like, can you take this? We just don't want to deal with it. And there are and that's great because that's a referral right then and there from, EDs that want to say, go to ortho, but we're in that department.
Hmm.
And there are times that it just comes right to me. The ED calls us because they work with our residents. There's a much more direct relationship versus other places in private practice. So it definitely is just like a pipeline to all of those types of cases.
As far as reimbursement models,
Hmm.
private practice, were you on salary? Are you on
Salary.
salary on all three of those models? Did you have a bonus structure? What was the
Yeah.
difference from that standpoint?
Yeah, no, it actually is interesting that all of them kind of overlapped. And I know there can be variety based on other private practices that do more of an RVU based model. Starting out, and that's what I would encourage a lot of my residents that start out looking at a more salary based model, just because you not sure what you're going to be able to produce, how you're going to perform first year out. And that's how I started. I was comfortable that way. And each practice I went to, just because I was, again, just starting off with them, even though now I'm years past residency, it's almost like starting fresh. So I started a salary base on each of those locations. There was bonus structure tied into that. Specifically, again, the numbers I don't know fully off the top of my head, but they'll do like a percentage over a certain amount that you make, and then that supplements your bonus each quarter. So there was bonus models structured into that, but majority being salary based. Some practices will say, do you want a lower salary with a higher payout in terms of bonus? There's always those options too.
Yeah.
I've seen those models versus a more steady, higher salary. And the bonus sometimes may be a little bit harder to make, but still could make it with just not as much. So I've worked with both those models.
And right now, are you RVU based?
No, actually, the hospital, they do a salary base as well. So
Okay.
they offer salary base with an RVU model to kind of track our productivity and any type of bonus structure beyond that. But I am salaried. Yeah.
Okay. So, I mean, whether they call it salary or RVU,
Yeah.
it's basically the same, meaning you're going
Pretty
to have a
much.
set minimum usually of RVUs, which equates to a certain salary. And then
Exactly.
if you do a certain amount, now they might do something I've heard of where they'll do an RVU donut, which means you hit a certain
Oh, yes.
minimum and then
Hmm.
you work for free for a certain period of time until you hit your bonus. And so you've hit the
Yeah.
minimum, you've made your salary, and then you're working for free for quite a period of time. And
Right.
then you eventually hit your bonus structure, which may not be that different than private practice, but just be aware of that when you,
Absolutely.
this bonus structure sounds so great. We call it a bonus. You're like, ooh, free
Yeah.
money. Like, well,
It's
it's
not.
not really free money. It's just a portion of the money that you've already earned coming back to you. That's
Absolutely.
it's not just
Absolutely.
free money out of thin air. It's money that you've already earned. You're just getting a part of it back. So
100%.
and that's
Yeah.
in contrast to my model, which is 100% money in, subtract overhead, and that's the money that you keep. It's just
Yeah.
there is no donut there. So people should be aware of that when they
Definitely.
understand or when they hear about RVU contracts or bonus structures or anything. Make sure you
100.
talk to co-residents, residency directors, have them evaluate your contract, because sometimes if something sounds too good to be true, it probably is too good to be true. Oh yeah, you're gonna bonus, and you're like, oh, you're adding up all your money before it even comes in
Yeah.
the door, and your chance of you actually
Absolutely.
hitting that bonus may or may not be good. It just depends on the practice.
Oh, absolutely. You got it. And and it can be sometimes overwhelming. You're looking at these contracts and it's your first contract too. And you're not knowing what you're reading and all these numbers are being thrown at you and not knowing what RVU models are in the first place. So definitely having co-residents, people that are in the practice already, and bouncing it off of them, and especially legal help and having lawyers look at all that to have the right questions to ask. Yeah, definitely important to look at.
Absolutely. I want to talk for a minute about I think there's been some positive movement, at least what I've seen with the Massachusetts scope of practice in terms
Yeah.
of ankle. You want to
Yeah.
explain that for anyone who maybe has the old version in their mind
Mhm.
of, hey, you
Yeah.
guys can't do ankle there, can you? And explain what's going on with that.
Yeah. So yeah, it's great you brought that up. One of my other hats, I am on the executive board for the Massachusetts Foot and Ankle Society. It's our state board. Currently president elect right now, and since being on the board, even as a board of trustee, that's been the primary agenda item on every meeting, along with all the other legislative stuff and education stuff that we do. But yeah, we've been in this kind of lull where we still technically cannot go beyond the ankle, okay, or the talar dome. And it's that old antiquated scope where these orthopods that are still kind of in the ways of, yeah, we just, that's the scope. We're not changing it. There's not a reason to change it, despite the advancement in training. And that's kind of where we're going to stay. And now, as we see a number of other states that have passed it in recent years, from New York and South Carolina, that were struggling for a bit, it's sometimes great to see that, but every state is different too, and we're working in a very unique climate where Massachusetts is very revolutionary in a lot of ways, and ahead of the curve. But when it comes to medicine, they're very, very conservative. And there's even colleagues on the board with me who are DPMs, and their dad is on the AMA and is a cardiologist, and get those emails, and there's word that it's like, we're just basically waiting to be the last state to pass it. And right now it's between us and Mississippi. So it can become a very stagnant state where we just want to be conservative and not push the envelope, let the other states do it. So it becomes a challenge, but we definitely have made headway. We've made a lot of relationships in the state house, a lot of senators that are behind us, because we've been putting out a lot more younger DPMs that do ankle. And even though that scope isn't there, a lot of it's hospital-based institution. They're going to be able to give you those privileges, whether the scope is there or not. It's their they may take a little bit more of that liability. But like I said, we don't have scope, and I'm doing ankles, and freely. I'm getting ready to book a total ankle at my hospital institution, and again, under the Department of Orthopedics, and allowing us to do so. So I think it takes that and those grassroots efforts that we're able to do these in these other hospital systems and show that this is what we're capable of, and just give us more of a power to do so. And that's building. So we're getting there.
Yeah, I think that's fantastic. From what I had garnered from my research, my minimal research, was that there was prospective bills in both the House and the Senate that were hopefully going to progress. You never know what's really going to happen, but maybe some prospective bills that are going to progress towards being voted on and hopefully passed into law.
Yeah. And I, there are those that word is out there. We've been there before. We have had some bills in front of them, and sometimes it doesn't even get to the state senators in the House to be voted on. It gets proposed, it's on the agenda, and then it never gets there. But we've been close, and we've had a positive trajectory moving towards that. So yeah, I feel we're a matter of a year or two away, which is continuing to push and get our faces in front of the right people. We'll definitely get to pass it.
I'm sure it will, with people like you pushing it. So good luck with that, and hopefully it gets passed soon.
Yeah.
I want to talk about you and I think are the exact same age. At least we did school and residency at the same time. I don't work with residents in my clinic and office. I do labs and we do teaching, things like that. But I don't have residents that are in the OR with me.
Okay.
One of the things I was thinking about when you become a residency director and you teach residents is, how do you keep yourself well trained on new techniques? You know how to do all the old things. You're going to let them do every this, that, and the other that you've done 100 times. How do you do it? How do you handle it when there's something that you feel like you want to learn a new technique or advance your skill set?
You're absolutely. I mean, I do think on one hand, it's trying to keep yourself up to date with that, where you feel trained well. And when you train residents, you got to, really rely on your training and knowledge and expertise, because it's one thing to do a surgery, but then another thing to have a resident there. They're very fresh, they're new, but not as well experienced, obviously. And you have to trust yourself that you're able to guide them through a case, and also if there was something that they may have done a little bit wrong, that you could fix it. So it takes a special kind of skill with that, and relying on what you know and how you do things. Yeah, you can kind of get stuck there, but the importance of also being up to date with some of these technologies so that these residents are being trained appropriately and not just being trained antiquated ways, because that's not going to be realistic. It is important. I do think it kind of forces me to keep me fresh, being immersed in a program, especially. I mean, before, it was very different where I did work with residents since I graduated, but just on an ancillary level. They would just come, scrub cases, and then head out. And then I was in my practice doing my own thing, rounding on my own patients and seeing my own consults. Now I'm actually immersed in a program, and which is nice because now the training's consistent. I can kind of follow and track their progress and be more consistent with them. But it does keep things fresh because I want their academics to be up to par. We're doing journal articles, journal clubs very, very often. Every bi-weekly, we're doing a number of presentations and having them present on some of the newer things. So in and of itself, just by that, it definitely keeps me well versed in a lot of things that are out there. I'm lucky that I like to be exposed to those things. I as a consultant for Stryker, I look at a lot of their products that come out. So I'm able to kind of see some of the newer technologies and be green in that sense. I hope to keep that energy up, throughout my career. But I do know as time goes on, as you get set in your ways, I mean, that definitely can be something that happens. But I think it's always important to keep an open mind and we're always learning. We're always training ourselves. I think that's important. MIS, I didn't get trained in that in residency. We didn't do any of it. I've been doing all my MIS by just my own training since I left. So everything's possible with any new technique that comes out just because you're not in residency. You can still learn.
Yeah, absolutely. I agree. MIS is one of those things that you and I, like I said, are the same age, and it just wasn't popular. It was popular a long time ago, and then it had its own issues and kind of went away for a while. But with the advent of some of the new technology and the new devices and the new things that they put in our hands, the ability to do things via MIS has certainly changed, and that is something that is completely revolutionary to me if having to relearn. Do you know how to do a Lapidus? Yes, I do. Do you know how to do an MIS Lapidus? No, I do not, but I will learn and I will figure it out. And then now I do know how to do an MIS Lapidus, right? Yeah. So it's interesting and it keeps you on your toes. What are some of your favorite procedures? You like trauma? You like reconstruction? What are some of the things that you really like to do?
It's funny. I kind of, when I get that question, it's like, it's sometimes the flavor of the week. Sometimes it's like, I'm in a wave of trauma and I'm like, oh, I love doing all the ankle RIFs and calc fractures. Let's churn them out. Let's get busy. It keeps things very exciting. And then there's other times where you get overloaded with that and you're like, yeah, I got to manage these patients and deal with all the potential complications with these traumas, and then really find your niche with the reconstructions you do. And I've done tons of, flat foot, whether it's joint salvaging versus fusions and subtalar and triples. To me, I love those cases. During my student years and residency, they seem to be like such these big, challenging cases. And now I revel in them. I just, with how many that I've done, it to me is fun. It's really fun to reconstruct a foot. Someone that comes in with such debilitating deformity, and you're able to really get them back into alignment and make them stable. To me, it's so exciting. When we say that we try to save lives, but we're trying to save quality of lives, and save lifestyles, because we're able to keep people on their feet and, save them from the deformation that's been happening for years. So I think overall, consistently, reconstruction, hindfoot fusions, and even flat foot reconstruction with calc osteotomy, those to me are like my cake and butter. Love it. Enjoy it. Anytime it's on my books, I'm excited for the OR.
Yeah, I think the hardest thing is not sometimes the foot. It's what the foot is attached to, which is the rest of the patient. And so the actual surgery sometimes is the easy part compared to the patient that it's attached to. So there's a lot of headaches out there. So
it can be. And even as I said, with those reconstructions, I love doing them in the OR, but they're off their feet for some time. Psychologically, they're maybe going a little crazy. You gotta manage them, managing expectations before, but throughout the whole course, and that's what I like about our profession, that we're actively involved in the post-ops. We don't often work with PAs that are seeing our post-ops. We're really involved in their care. And I think that goes a long way with patients. That becomes part of the whole process. And I love that too. I do like it. As much as sometimes they can complain, I want to work through things with them to truly help them, not just the day of surgery to help them.
Absolutely. You want to, speaking of surgery, want to jump into some cases here and talk through some things?
Yeah.
We'll be right back after this. For more information, go to podiatrygrowth.com/podpatrol.
So the people have signed up for the 5 email course and 30-minute free conversation with you to analyze where their marketing needs improvement. What steps can they take next?
Yeah, the next step is a deep dive. It's what I call an online practice x-ray. I look into your Google Analytics, your Google Ads. And then the last part of the online practice x-ray is to provide you high ROI marketing plan. It's a really in-depth diagnostic that will give you a clear direction about what those next steps are to help you grow your practice. This is something I generally charge $2,000 for, but since they're Pod Patrol listeners, we're going to chop that in half and charge $1,000 for this diagnostic. You'll have a written document at the end with the competitor analysis, what you're doing now, and a clear marketing plan to make sure that you can be cost effective when it comes to marketing your practice.
Absolutely. I love to hear that. Paw Patrol listeners are getting 50% off from Jim McDaniel, marketing expert at podiatrygrowth.com. If anyone's interested in more information, they can go to podiatrygrowth.com/podpatrol.
So this was this is a kind of classic case of mine. And I brought it up because, we talk at MIS, definitely failed years prior, but I think with the advent, as you said, I mean, it's really kind of here to stay, only because the techniques are different. We're thinking about it. We're fixating it the right way. So I brought this example up just to kind of really show that we're able to reconstruct and do a good flat foot reconstruction. And I say that too, because a lot from a patient's perspective, when they ask, what can you really do for a flat foot aside from orthotics? And we fail that. Well, we can really recreate an arch. We can get you stabilized. And now that we can do some of these procedures via MIS, it's great. So this was an example of a calc slide that I did. I still do, percutaneous 2 screws, but the calc slide to me with the MIS approach, using that burr from a lateral and make that cut, it just saves so much OR time, saves so much dissection that can already be a sensitive dissection. And so this was paired with an Evans that I, thought came out really well, and the patient did remarkably well. And I think from the MIS, it doesn't necessarily save healing time, but I do think from the osseous standpoint, but it does save healing time from soft tissue. And I just think it allows them to rehabilitate faster. So that's kind of the case that I wanted to bring up. And it always brought up in my mind, can we ever go to MIS Evans? I mean, it may be tough. I don't think we can right now, but is that in the future too? We'll see. I don't know. But
what size burr do you use for your MIS calc slide?
Yeah, so this is the burr that I use is a 3.2 cutting burr. It's a longer burr, the actual length, I forget the length of it. But it's definitely a larger burr that goes across. You do have to cut it in its quadrants.
That's what I was gonna say.
Even though it's a decent sized burr. So there's nothing that fully goes across. But I think for the control of the osteotomy, you don't want to fully go across. You do want to keep it to those quadrants. But yeah, that's typically what I use. There's some other bigger burrs and other size burrs too. But I've just found comfort in that. Not overly, it's aggressive, but not too aggressive, to not resect too much bone. I don't know if you've seen, I actually was over the weekend at a course, and they're actually coming out with guides for the osteotomies, for Zadix and calc osteotomies. And us, I know we've been doing them on the fly, and I, comfortable doing them on the fly. But I think from a training wheel standpoint for residents, it's nice. So it's a nice option that's out there, that's coming in the new year. So that's something definitely to look out for.
That's what I was going to say. I've used a K-wire before.
Yep.
Tyler Gonzalez, among others, has described for his MIS Zadic is just popping a K-wire up, and it's super cheap, and it's an easy way to get a visual guide, if nothing else, of radiographically and maintaining your alignment. Because I found, and I did some MIS cases today, the hardest part about using the burr is the fact that it's hard to see the angle of your burr, because the angle of your burr is blocked by when you take the x-ray. Your hand or the burr unit is in the way, and you can't truly see where your burr is. You have to move your hand or your burr to move to be able to see where it is, and all of a sudden that's not where you want to see where you are, if that makes sense. It's like you have to infer, okay, I'm here, now I have to move my hand. Okay, that's where it is. Okay, now bring it back. I think that's sometimes the hardest part about MIS is keeping track of where you are.
Oh, absolutely. It's knowing where you are. It's spatial awareness. I mean, of course, that's true of any cut we do, but when you're looking at a limited visual field, because it's a percutaneous incision, it takes a lot of skill, a lot of finesse. It's that pivoting motion that you work with the burr. You really want to get that down, because and I see it with my residents, unfortunately, is that they want to just, like a saw, want to take the whole handpiece and kind of drag the burr across. And I tell them that's not what you want to be doing, because that will just rip the skin open. You really want to pivot on that entry point and stay in the same plane. And that's not an easy task. So yeah, using the K-wire is a technique that I've helped with residents that have done. Again, I like to, I just go for my cut. I'll line it up and I'll look on fluoro, and I'll start it off and just see the outline of it a little bit. What I also do is I actually mark out on the skin. I'll mark out the skin, the trajectory of my osteotomy. So I'm also kind of using that, knowing where I'm swiveling my burr kind of gives me a little bit of guidance as well. But as I said, working with residents, I really do want them to utilize any types of tricks and pearls. So we've worked with a number of those kind of options that definitely do help.
You were asking about an MIS Evans. The reason you can't, for any of the younger people, it's really tricky to do an MIS Evans is you're putting something in there. You're putting either bone graft or a metallic graft, some sort of wedge graft to keep your osteotomy open. But even if it's not technically MIS, which I talk about MIS a lot, and I host another podcast about MIS, so I'm kind of entrenched in the world of MIS. I still don't know what the technical definition of MIS is, if it gets over a certain number of millimeters. But point of that is, even if it's not truly MIS, you can still do that Evans through a relatively small incision, especially even if you're using a saw, but especially if you're using a burr to make that cut and wedge it open. You just have to make it big enough to get whatever you're putting in there through that incision, but it could be relatively small.
Again, kind of calling it like a mini open. And I think, posing the question, because I, again, talk about it with other colleagues with some of the lectures or conferences we do, and that's been posed, and they've actually tested it. They've looked at it like, let's try different techniques, let's try things. And ultimately the answer was, no, we can't. We just can't do it. And that's fine. I think with what you said of keeping it from a mini open, that you don't have to do such a large extensile incision, you're definitely able to do that. Even if you're working with the burr instead of a saw, it achieves the cut. Keep it mini open to get the wedge in. So yeah, we can make our incisions smaller, but a true MIS approach, I agree. I don't think it's possible.
Sure. Are those 6.5, 7.0s bigger? 7.0s?
Yeah.
So for anyone just listening, we're looking at a flat foot here with calcaneal osteotomy and an Evans with some headless compression 7.0 screws in the posterior calcaneus there.
Yes.
All right, what do we got here?
Yeah, so I've actually been getting more and more involved with a lot of Haglund's resections. Obviously, I was doing a much more open Achilles detachment, shave that bump down, use the bone wax, reattach the Achilles, whether speed bridge or other soft tissue makers. But, seeing a lot of the colleagues out there and doing some of these approaches, especially when it's a true Haglund's with not much Achilles involvement, I'm thinking, let's kind of go after it. Let's see what we have available. And MIS, when I first did it for a Haglund's, I was just literally taking a lateral approach and kind of just burning down the bone, just shaving it down. People always hear when they do joint fusions or burn bone through a MIS, where does that go? It is pretty effective because you're just basically converting into a paste, and it just really exudes out pretty well. So when I did that, I thought it was very simplistic. I thought it was, kind of not potentially the best way. Maybe there's another better way MIS to do with this, but it worked. It did help that patient. Didn't have to touch the Achilles. They had a quick recovery, no fixation, and they were on their way. But seeing some of the more larger deformities with that pump bump that's there, again, I'm electing to do this with patients that don't have much Achilles degenerative changes and a lot of Achilles tendinosis, that I don't have to really touch that. And a true pump bump that I'm able to just kind of do a Zadig, where I'm doing a basically closing dorsal wedge osteotomy. And I think, we'll show kind of those slides of what that looks like, but we're closing that wedge down. We're bringing that posterior tuber up. Yep, right there, to basically change the trajectory of that calcaneal inclination and basically get that pump bump away from the Achilles as it passes by. I actually started kind of going more posteriorly, and that's what that other slide showed, of a more posterior wedge that was taken. I used to do it kind of in the same vicinity as a posterior calc slide, but now just being a wedge that we're taking and flapping it across and closing it down. Easy way to close it down is just dorsiflex that foot. The Achilles will pull on that tuber, and it reduces it for you, and you get a good reduction. The modified Zadig that we're showing in that illustration, you're actually going right after that pump bump. You're going right after it, so you're closing the wedge dorsally, but you're also resecting the bump with it. So it is a much more posterior placement. You have to be a little bit more careful and diligent with your saw and your cut. So that's the one caveat. But I found it to be pretty effective, because now you are taking away some of that inclination, taking away that Achilles stress, and you're also completely eliminating the actual pump bump versus other approaches where it's technically still there. It's just not in the way of the Achilles. So, but I've been seeing really good results with this approach.
Yeah, I've been seeing really good results too. I do an MIS Zadic, I do an MIS Achilles detach, reattach, shaving the whole thing down and then reattaching the tendon via MIS approach. And to be honest with you, they both have pretty good
Yeah.
outcomes. As
Yeah.
long as you're decompressing the posterior aspect of the calcaneus, whether you're shaving it down or anteriorly translating it, because you're taking a wedge out and dorsal wedge resection and anteriorly
Yeah.
translating, you're effectively shortening the tendon too. So you're
Exactly.
getting some
Exactly.
decompression of the Achilles. You're resolving the posterior point, pointing bone posteriorly that was pushing into the tendon. So these people do fairly
Yeah.
well. I did find that the osteotomy takes a long time, and it's easy to get off
Mm-hmm.
track, and that's where
Yeah.
I was talking about putting the K wires in subcutaneously. Just pop them in the bottom of the foot and lay them against the lateral calcaneal wall. And so when you take your X-ray, it guides you. Found that to be easy. And even with those, I found myself wanting to kind of
Yeah.
wander with the burr. Do
Absolutely.
you have any tips for keeping your burr straight along two lines as you try to take
Yeah.
that wedge out?
Like I said, it's just taking your time with it. I mean, I don't think I have any specific tip or pearl. It's really taking your time. For this approach, again, doing it with the KYs, I do want some guidance radiographically and something there to kind of visualize, but just also knowledge that you don't want to fully rely on that. There's nothing you can fully rely on with these cuts. You got to be really careful. I'm looking on fluoro pretty consistently, doing a swipe, and then checking and then doing another swipe. The other thing I do sometimes is, how much is too much? I'm not taking a huge wedge at first. I want to line myself up and kind of get my trajectory. But what's also nice with these closing wedges is that I kind of treat the burr like a saw and do kind of a reciprocal planing technique. So if I'm not taking a huge wedge right from the get-go and closing it down, you don't have to. I get the pump bump, I get a little wedge. Yeah, I need a little bit more. Well, I can always do that. I just kind of reciprocally plane and just kind of close it down. As I said, dorsiflexing the foot as I'm doing that automatically closes the posterior tuber to the rest of the calc. And you can really get much more reduction just by doing that versus taking another wedge, which can take a lot of time. So yeah, that's what's nice about it.
Absolutely. These patients do so well. And
They
that
do.
recovery is very quick. The calcaneus obviously is a
Yeah.
vascular bone, good healing outcomes. Obviously, people might think, well, hey, what about calcaneal fractures? That's its own animal of interarticular nature mess. This is just a calcaneal body osteotomy. Has really good healing. How long are you keeping patients off of it?
Yeah, I mean, I'm trying to get them going as quickly as I can. I obviously keep them off it for those first 2 weeks. They're definitely offloaded that way. And I think I do that also just kind of really dorsiflex and keep them in neutral. I don't want that Achilles to contract. Even though I don't touch the Achilles, I still just don't want it to contract. I really want to keep it to neutral. I think also the dorsiflexion in a cast will really help kind of hold that together. But after the first 2 weeks, their X-ray is looking good. I am transitioning into a boot. I'm not necessarily getting them weight bearing right off the bat, but I am having them a boot to have a little bit more of that freedom to at least potentially start doing some partial touchdown weight bearing before they see me again in a couple of weeks. I don't want them waiting to 5 weeks post-op, and now we're going to get started weight bearing. So I'm trusting these pretty well. I'm not cutting that plantar hinge, so that's already kind of intact. With those two solid screws, it's pretty stable. So yeah, I'm kind of getting them going about 3-4 weeks out.
I agree. It's a very stable construct. I agree. We get these people moving pretty quick.
Yeah.
All right.
Yeah.
This is a mess.
It's a mess. A little touch of Charcot, I like to call it, but this is a mess. So, and what's interesting about this case is that, sometimes we have to really pivot with them, whether it's from surgical decision making and what we do in the OR, before the OR, after the OR. And then there's times where the OR is not set up for success and we have to pivot there. So, it's a challenging case, but sometimes can be very rewarding. And in this patient's case, she was just ecstatic. It's still like not a beautiful foot at the end result, but she is ecstatic with what she was dealing with. So she had bad Charcot, obvious, history, longstanding history with osteo in her first ray that had to be resected. So she's already been down the road of amputation. She does not want to lose her leg. She has this lateral draining sinus from the fibular malleolus. So obvious osteo that's been there. She's been at a wound care center that she's been treated just wound care wise and offloaded. Obviously not going to do it. And even though these are non-weight bearing x-rays, you can just tell the talus is non-existent at this point. And tibia is just driving into the subtalar joint. So So yeah, this was a very challenging case. It was one from one of my colleagues down South Shore area, in south of Boston, and said, "Yeah, I want you to go into town, see my colleague, and let him take a look." And we're like, "Yeah, you really want to get on your feet. It's going to be a long endeavor, but she really wanted to save her leg and get back to walking, get back to work, and she was willing to do it." So yeah, so what we were looking for. So what we obviously had to do, there was pretty much non-existent talus, although there still was a little bit of bony components to it. So we had to really do just basically total telectomy, which the job was already somewhat done for us getting in there, but we did remove the rest. Fibular takedown, that obviously had to go just for exposure, but also wanted to biopsy and, see what osteo was growing there. I like to do, femoral reamers for these, just to kind of get the contour of the bone. There are these really cool ankle truss systems that are osteoconductive, osteoinductive, really fills in that space nicely. And if I were to stage this later and maybe get a nail up there, it would fit right there. So it's a perfect thing, but my OR said too expensive. So I was like, all right, well, we can still make do. I would love maybe if just a femoral head graft. They have them down there. Let's just work with that. We'll use tons of other bony, other bone graft materials, regenerative bone stuff, and really get them going. Maybe work them up for bone stimulation, which we were able to do in this case. So felt confident with the femoral head graft, did the reaming, see a good kind of outline to get that graft in there, which we did, kind of obstructed by the X-fix that we have there, but got filled in pretty nicely. Got it out to length. That's a big one here. And also getting that foot planograde. Basically, I'm setting this patient up to have a hind foot stability, almost creating a flipper foot. So I was just like, yeah, let's get you X-fixed. Let's get that draining sinus closed, let the wound heal, which it actually remarkably did. That was probably the first thing that healed out of everything. And she was doing really well. But unfortunately, what we really wanted to do with the femoral head is not that it's a femoral head. It's a patellar graft. So definitely not the choice that I wanted to use. In the case, the nurse opens up the femoral head graft, gets it on the table. We're prepping it. We're doing all the bone graft. Get it in there. It looks great. Femoral head's expired. So had to take the whole table down. We're in the OR. It was a whole big mess that we had to get, patient compliance and inform the patient and do all that. It all worked out well that it, didn't cut any further contaminants or other issues, but we couldn't use it. We couldn't keep it in. And there was no other option except for
So what, I'm not trying to be insensitive. Obviously, the patient that it came from is expired.
Yes.
Right? It's dead bone.
Yeah.
How does it expire? Like what?
It's an interesting question. I know. The way they have it stored on the shelves and where these expiration dates come from, I don't know. And I was like, to me, that's not a contamination. It's already sterilized. It's already ready for use. Why, if anything, it's just potentially structurally not sound, or maybe it's going to fail in that way. But I would have much rather gone that route than what we had to end up using. But according to compliance and the OR stuff, they're like, no, we gotta take that out. You gotta take the whole table down that it fell onto. So all the equipment I had on the back table, it was just,
oh my God.
It was already a long case. So it became an interesting scenario, but we had to pivot and use whatever graft that there was. And, like I said, it kind of helped strengthen my case of getting that ankle truss approved, because eventually I was like, this would have saved all of that. So, but unfortunately,
yeah, you should throw that in their face.
I followed up and said, listen, this is what I tried to avoid. But no, we had to pivot. We went with patellar graft, did not heal, which I knew it wouldn't, but we just gave her, again, just to get her stabilized. It did heal the sinus tract. She healed the wound. So there was that win. But the patellar graft basically
did you do anything to the patella? Did you shave the cartilage?
Yeah, what I do typically with the femoral head is to denude it, roughen up the edges with a bunch of reamers and burrs on the back table, fenestrate fenestrate it quite a bit. And then I'm getting bone marrow aspirate. I'm using some of the other bone regenerative grafts that are out there with different companies, mixing it together with their own blood, making a big kind of paste and mold out of it, and then just soaking the femoral head in it. Let it soak into the fenestrations, let it soak over it, and then implanting that in there. And then do it, and then any excess I have, I'm implanting in there. Did the same with the the patella, but the obvious anatomy of the patella doesn't match the femoral head. And so that was my bigger concern from a structural standpoint, filling it in, of getting the structure of the hind foot and ankle that I wanted. And yeah, that was a big concern. And because of that, based on its anatomy and the articular surfaces, the grooves that are on the underside of it, it just doesn't fit well. And I think that was a big component of the failure, among other reasons. But it just basically completely resorbed. We were not seeing any consolidation, and if anything, just vacancy of what that graft was. Kind of looked like what it did before the first case. And so we knew we had to pivot, and I had to tell the patient, listen, we have to kind of go a different route. The plus side, we got the wound healed, and we were treating her with the osteo that we saw. I got a clean margin from the fibula. So we had some confidence that, we were somewhat clear of that, and the sinus tract, filling in nicely. I kind of pivoted to say, let's get this frame off because you want to go back to work. I do need to transition you to an internal fix, but we do need to revise it. And so that's kind of what we ended up doing. So took her back, got the frame off, got into that joint. Like I said, the patella was just basically nowhere to be found. It was, if anything, it was just fibrous plugs that were in there, and just, yeah. So we reamed it a little bit. I didn't want to lose too much length, so I just did a little bit of freshening up. But then the same idea, got on that fresh femoral head this time around and did the same prep that I did. She was already on a bone stem. I had tons of bone graft and other materials to utilize, and just coated and covered that thing. And then this time around, used a steady, stable internal fix with a TTC nail, and got it through there. The thing that I always want to be careful, why I like that ankle truss, is it's already designed to have a nail go through it.
Yeah.
You can really crack your bone and it destroy it. So I pre-reamed and pre-drilled that femoral head once it was prepped, so that it can line up and almost have a tunnel for it, so you don't stress it and keep it intact. So this is actually the final construct. I know the resolution is not great, but now she's finally filling in. She's healing well. This was some of the initial x-rays we got, but she's finally fully solid and consolidated. On exam, her foot is just, it's locked in, it's stable. So I was finally happy to see that at least got her that success. And again, like I said, she was thrilled. She's like, my wound's healed, my foot looks straight. This is something that I hadn't had for years. She's been off of it. And so it was a win after all those headaches. Sometimes it happens, and you just gotta remain patient with these patients, regardless of those hiccups. And sometimes with that, it's an extra headache, of course, but the end result is getting the patient on our feet.
Yeah, that's fantastic. That looks great. That's a great outcome for her. The hard part about Charcot is that you win until you lose. Even if you win, at some point they come back. You're like, what happened?
Oh, absolutely.
So you try not to high five too much, but this looks fantastic, and that's a really good outcome. So great.
Like you said, I appreciate it. Yeah, like you said with Charcot, it's sometimes it looks great, but managing these patients' expectations too. I mean, at least not dealing with the BK right now. There's always that risk in these patients. It's unfortunate that they have to be afflicted with it. It's a devastating diagnosis, and I say that from the get-go. I'm saying this is not. You may know the knowledge of it because other doctors talk to them about it, but I've found that it is not a whole lot of education from some of the other providers, and they say, "Oh, this looks Charcot, go see this provider." I really spend time talking that it's devastating. It's definitely a huge big high risk limb threatening disease. But we can fight and try and see what we get.
Yeah, absolutely. I mean, that's all you can do.
Absolutely.
You could tell them, hey, we can give this a shot. It's an uphill battle. Maybe a few battles, maybe an expired femoral head with a patella detour back to another femoral head, but we didn't see that coming. But we could do BKA, right? So you give them the option, or you could live with it as is. I tell people that all the time. You can live with this as is. You're already doing that. If you're happy with that, if you don't mind going to the wound care center, you're worried about losing your leg. If something were to worsen, then you could certainly live with what you've got. So it's a tricky situation. Like I said, it's a complicated foot attached to a complicated patient, which makes our jobs a lot harder, but it also keeps it more interesting.
It does. And like I said, I mean, it's giving us a variety of pathologies we see and how we can help people in a multitude of ways. And it keeps it fresh, keeps it exciting. And patients like this, as much of a struggle and challenges that there are for us as surgeons and them as patients, but they really become appreciative because they know what potential devastating outcomes there can be. And, they really are appreciative that they show how much of their lives you're improving or you're impacting. So it's rewarding.
Absolutely. There was a case I had one time, just talking about complications, where they brought an ankle fracture set, and they did the thing that has only happened a very few times, where they lift the tray and then they hold the sheet up to the sky and they're like, nope, look, it's contaminated. And so they had to take the whole tray and set it and get rid of it. And then I said, okay, what else we got? The patient's on the table. They're asleep. They're ready to go. They got a broken ankle. I'm like, do we have any more ankle trays? They're like, no. I was like, okay, what do we have? And they busted out this set and I start rifling through it. And I'm like, what is this? And they're like, this is a distal radius plate.
Wow.
So I took a distal radius plate and I kind of turned it and I kind of held it up to the fibula and it kind of went down and it had like a little L and like a little backwards L. And I was like, yeah, I think I can make that. I put it on. So there's someone in Tennessee. It's where I used to live. There's someone in Tennessee walking around to this day. Well, maybe they had to take it out, but to this day, to my knowledge, they have a distal radius plate holding their fibula together.
Amazing.
So at some point, you got to do what you got to do. And you can't anticipate some of those things, but
no, some of these cases that are already challenged, you going into battle, more things that you need, there's more chances that things can go awry, but you got to be prepared for any little thing. And even some of the things you may not be prepared for, like this, but you just learn how to pivot and just stay patient and know what the end goal is at the end of the day.
Absolutely. So if anyone's interested in checking out your residency program, I would highly recommend it, but tell them what they need to do. Obviously, look it up, Boston Medical Center, Brighton.
Yes.
Look that up and get some more information that way. Do you have any other parting words for anybody who's interested in the program?
No, I'm very receptive to students that want to come through. Obviously, we're in a social media world, so students reach out to me via Instagram and they go into my DMs, and I'm fine. I love getting them and seeing when they would want to visit or how they want to extern, give them the right contacts for email for my residency coordinator, how to apply. I get them in touch with my residents that if they want a day for a visit. So I'm always answering those calls. So whether it's email or Instagram or some of these other profiles that I have, definitely reach out.
I think it's just Dr. David Sipala is your Instagram handle.
So it's Dr. Dave Boston.
Dr. Dave Boston. Check him out on Instagram. Reach out if you're interested in the program. Check it out. Thank you so much for joining me tonight. I appreciate your time.
No, I appreciate you having me. This is great. Thank you so much.
Absolutely. Thank you guys for joining us on this episode of Paw Patrol with your host, Dr. Jeff Dikis, joined by Dr. David Sipala. We'll see you guys next time.
Thank you.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.